Okay, hello and welcome to the SHSMD webinar, Key Market and Provider Metrics to Drive Strategic Service Line Growth. SHSMD would like to extend a sincere thank you to HSG for sponsoring today's program. This webinar is now being recorded and is broadcast in listen-only mode. We have allotted time at the end for Q&A, but feel free to click the chat icon in the lower right-hand side of your screen to submit questions or comments throughout the presentation. It is now my pleasure to hand it over to today's speakers, DJ Sullivan, who is Chief Strategy Officer at HSG, and Travis Ansel, who is Chief Executive Officer at HSG. DJ and Travis, thank you for joining us. The floor is yours.
Thank you so much, Tom, and welcome everybody this afternoon. We appreciate you joining us. As Tom said, my name is Travis Ansel, CEO of HSG. Today, we're talking about key market and provider metrics to drive strategic service line growth. Today, we'll be focusing on how to measure and interpret key data analytics as you, as a health system or a large physician practice, focus on growing market share and growing service lines overall. My background is purely in strategy consulting for hospitals and health systems. So I've worked in this industry since the early 2000s. And with HSG for the majority of that time, as our scope of practice, we work basically with nonprofit health systems across the country, helping organizations with the analytics to measure their market and provider performance and translate that into strategy and implementation. DJ?
Yeah, then DJ Sullivan, Chief Strategy Officer at HSG. Been with the firm for 10 plus years, mainly focused on a lot of, obviously, our ambulatory growth initiatives with our partner health systems and clients. Also do a lot of claims data analytics, oversee that aspect of our business where we utilize, proprietary data sets for a lot of ambulatory growth, outpatient market share metrics, patient leakage type metrics, aspects like that. So we've kind of helped build that and provide insights and strategic support for organizations on really maximizing the ROI in their ambulatory investment.
Great, thank you.
Then the one other thing I might add to that, Travis, so we are moving to that next slide, with a partnership with Archbold, who's a health system partner of ours in Southwest Georgia, as well as then Tiller Hewitt Healthcare Strategies, another partner of ours that we've worked closely with over the years as part of the SHSMD Virtual Connections or Connections Virtual Conference next Friday. There's a shameless plug for an incremental session. It is a deep dive into an actual case study with Archbold that may be valuable for many on the call if there's insights around this, some of the success that they've had as an organization of, multi-million-dollar increases in their net patient revenue from ambulatory investment aspects that we've been partnering with them on. That would be a nice use case for you to kind of gain access and insights into.
Yeah, perfect. And also a reminder on this slide that if you'd like handouts from today's presentation, please leave your information in the post-webinar survey that will pop up at the end of today's presentation. So today, what we'll talk through, I want to talk through key metrics for utilization as we see organizations focused on service line strategy, our observations on data points that help identify growth opportunities, and basically how to merge all those things together. And then we'd be happy to take your questions at the end of the time. So when we, as a third party, think about what data sets do health systems need to basically comprehensively evaluate opportunities for service line growth in their market, we kind of put it in 7 buckets, and recognizing that once you are on the ground and working in a health system, that there are many other political and cultural data points that need to be qualitatively evaluated when thinking about growth. From a third party's perspective, when we're talking about quantitatively, what can we evaluate in order to identify opportunities, set strategy, measure, and then manage performance. The 7 things we recommend looking at, and we'll talk through today, are 1, market share metrics. Most health systems, of course, we see utilizing inpatient data. We're big proponents of, given that healthcare and from our perspective, healthcare strategies are really driven by the outpatient ambulatory physician office space. being able to measure in both environments to both understand our current performance and look for incremental opportunities is critically important. Two, most health systems we work with do some form of provider need or community need assessment, which we think is great, but like to see that data utilized strategically and not just from a community need perspective, but basically utilizing it to understand provider supply and demand perspectives at the overall market level as well as the strategic market level. And we'll talk through a little bit of that. Succession planning for the longest time, at least through my career here in the healthcare industry, was not necessarily considered a strategic issue. But when we look at the amount of providers across the country that make up our client medical staffs that are succession planning risks between now and say 2030, strategic replacement and our strategy for replacement of physicians who may be transitioning out, having data elements around that we view as critically important. We see looking at our existing employed network, and I'm going to generalize a little bit here, but for most health systems, the strategy is really driven at the employed provider network level. Now, it's certainly not true for all markets, but it is for the majority, especially if you're in our half of the country here in the Eastern US. And so having metrics around how we're performing within our existing practices, where our opportunities are for internal growth without necessarily a lot of incremental investment versus service lines where we have to build additional capacity, critically important. Geographic footprint, as our general philosophy is health systems need to be in the markets that they want to win in. So thinking about what our footprint looks like, what we're asking of consumers to utilize our services in terms of when they get in their car or they get on their computer, what are we asking them to do? And then the last one is so much of what we focus on from a patient lives perspective is really the relationship with primary care. Not saying that primary care is the only way by which a health system partners with a patient for their patient life, but primary care being a big portion of that. So how do we, as we build the network that will help us with patient life acquisition, how do we ensure that what data are we utilizing to ensure that those investments are helping us keep those patients in our network? And so looking at the point on this slide being that all of these things, we see a lot of health systems utilizing some of these data points independently. We see more and more health systems utilizing them, collaboratively to paint a holistic picture, kind of by service line from a market perspective. And that's what we would advocate for, is utilizing them comprehensively to decide where our investment needs to be, especially in today's healthcare environment where we can't invest in everything. What are our biggest opportunities and how do we prioritize? And so starting with market share metrics, so one of the things over the past 5 or so years, especially as we've gotten heavier into the data analytics spaces, we've recognized some of the variation in utilization of inpatient market share data by our partner health systems. And so at a basic level, I think we would advocate that all health systems have a comprehensive understanding of their inpatient market share, especially for at least their core service lines, if not overall, but being able to differentiate that across markets within your service area and against competitors. And so, when we look at state level market share, it's, again, core service lines, who are our key competitors, how is our performance in those service lines trending over time? And as we try to start translate that into a vacuum, if we look at inpatient market share in a vacuum, we translate that into strategy by saying, where are we growing, but especially where are we losing? And so this particular client, of course, the data is blinded. But you can see from a COVID standpoint where, in 2020, their total market share was about 28% of the total orthopedic market, and having fallen to 25% from an annualized perspective over that 3.5 year period. leveraging inpatient data that way to say, that's a service line that, we'll have to look at the financials to figure out if we want to be in, but having that awareness of our performance is critical as a part of the overall picture to understand how we're doing.
And one note I might add to that, Travis, too, is I've been surprised as we've partnered with a lot of health systems over the years on the data access seems to be integrated within most health systems. I think the information aspect of that is where some of the disconnect seems to occur of we know we have market share data within the system somewhere. The utilization and translation of that into information that can be executed upon and strategies and decisions made upon, I think is where we see a lot of organizations really trying to think about what is that next level and how can we transition that piece.
Yeah, that's a great point. And then similarly, but with maybe a little bit of a differentiation, outpatient and ambulatory market share is something that we think is critical that health systems begin to understand and utilize. And I say that because even in our larger systems, the plurality, if not the majority of the dollars are coming from the outpatient and ambulatory environment, especially for our regional and community health system partners. It might be upwards of 80% of revenue is outpatient and ambulatory market share. So, even if you've historically evaluated your performance through inpatient data, because that was the only data set available, the proliferation of claims-based solutions allows health systems to understand, that same data. And in this example, orthopedics allows us to understand that same data, but on the outpatient perspective. So how are we doing in capturing those outpatient procedures? How are we doing on outpatient joint, outpatient orthopedic imaging, outpatient hand, outpatient trauma? So being able to not only have that inpatient perspective, but also that outpatient perspective, and again, measured and trended over time, again, utilizing this client as an example, a 2.5% drop in orthopedics, on the outpatient side, we tend to look at it more quarterly as opposed to annually. But a 2.5% drop over the past 5 measurement periods representing, the last 5 quarters. That portends, where we may want to think about is, orthopedics is generally a service line where most health systems want to succeed. So being able to measure that and see that there is that corresponding drop on the outpatient side may help us prioritize orthopedics for a shift in what we're currently doing as a strategy. And then we're often asked, okay, so if we understand our share, whether it be inpatient or outpatient, how do we evaluate what it should be? And recognizing that every healthcare market, there are no two alike healthcare markets in terms of their competitive dynamics, in terms of the consumer dynamics, in terms of the physician, historic physician practice dynamics. Where should we be? And one of the things we often focus on with health systems is, one, outpatient market share as a whole shouldn't be, there shouldn't be a target, there should be a benchmark, and our goal should be incremental performance improvement over time, which necessitates measuring data over time. But also, if we're really focused on creating internal benchmarks, our own service lines should be a guide for how we can succeed in the market. And so if I'm comparing, this organization that has, across most inpatient service lines between 60, 70, 80%, I start to look across from left to right and I see, variation start to occur, especially on the outpatient side. So if I'm looking at ambulatory, I see we're keeping about half of all orthopedics cases on the ambulatory side, but 65% in the general surgery side, 88% on the cardiothoracic side, 70% on the vascular side. That gives me a relative idea of what our organization is capable of if we can align our access points, our access to specialists, and the execution of our specialty strategy. And so that gives us the idea of what could we aspire towards, but would always want to push back and say, each of these represents an opportunity to start measuring these things and measure against our own internal benchmarks going forward. So with market share, kind of identifying how are we doing in the market, what are we trending well in, what are we not trending well in, and how might that help us start to prioritize what specialties we want to focus on. We would recommend typically looking at that before we start to look at provider supply and demand and utilizing provider supply and demand data as another directional indicator of how we can help shape our strategy, as opposed to maybe some of the more top-down approaches we see from health systems at looking at provider supply and demand first, and then trying to figure out what they can add that might fit within the supply data and hopefully also align with strategic need or market share goals. And so when we talk about looking at provider supply and demand data, one of the things we really advocate for, well, there's a couple of things. One, making that data as granular as possible. And so while we may look at something like cardiothoracic surgery at a primary and secondary market level, because it really takes that much population to support a cardiothoracic surgeon, things like primary care, women's health, specialties that lend themselves really well to specialty clinics that have a lot of in-office stuff like cardiology, orthopedics, taking that community need data and getting it as granular as possible to a zip code level or to a sub-market level, where we're really kind of aggregating data that allows us to think about who are we competing with, how are patients seeking care in that sub-market, recognizing that even in the smallest health system service areas, there are different pockets of populations that seek care differently. So getting that community need data to as granular as possible, and utilizing that again as a data point to help us shape what we're seeing in the market share data and think about how we change that market share data. And this is an example of what happens when we regionalize something like orthopedic needs. So continuing our theme of just looking at orthopedics, this is a market that we worked with and of course blinded all the data. But when we start looking at orthopedics across this market, what we saw was reasonable outmigration from this particular service area. So a lot of in-market need. So we saw high need for orthopedics kind of throughout the market, but then especially looking at the regionalization within this health system service area, where where the hospital and its competitor are located, as you might suspect, a ton of orthopedic supply, and around the periphery and some of the core submarkets that were both health systems were kind of either expecting to come into the market, or whose patients were or whose consumers were leaving the market in totality to seek care. When we regionalize supply and demand data, it points out opportunities where we might think about if we're using orthopedics as an example, what is our access point strategy in, say, our Northeast market where there's a severe orthopedic need? How do we layer together things like primary care, immediate care, urgent care, some form of imaging and ancillaries, and then that specialty clinic presence for our appropriate specialties, in which I would argue anybody who wants to compete in orthopedics, especially in a market that is as broad as this one, needs to have a strategy for getting providers out into the communities as opposed to expecting patients to spend the time driving in. And so that's how regionalizing can really support strategic decision making.
And Travis, we actually, before you transition, we had a question on what resources maybe we suggest for doing a provider need or demand assessment.
Shamelessly, that's something that we, along with about 4 or 5 other companies, do really well. And so I'll leave it there. Happy to provide, if that person wants to reach out to us, happy to provide our information along with some referrals outside of our organization for looking at that type of data. And then similarly, looking at when we look at provider supply and demand, one of the things we have to layer in is kind of our challenges for succession planning. And as I mentioned earlier, if you'd asked me 15 years ago, is succession planning a strategic venture, I would have said, no, probably not. Just something we need to be aware of. But when we start to look at, even in this example here, when we start to look out 3 years and see 33% of our current primary care supply being above the age of 65, when we look at 33% of our medical specialists, when we look at a quarter of our orthopods being 65 in a 3-year window, that creates a real challenge to just maintaining the status quo. The good news is, across most markets, that's a relatively equal challenge, and every health system's dealing with it the same way, which is, oh my gosh, what are we going to do? But being aware of that, and I would say having the forethought to not only think about, okay, what is our problem, but how are we going to deal with it outside of just hoping that we can recruit to not only keep our current supply, but add incremental bodies, is really thinking about kind of our clinical practice model. There's obviously been a lot of emphasis in thinking about how we shift, clinical practice from being a physician and an APP driven to, how do we have a physician supporting a team of AC or supported by a team of APPs? How do we use everybody at top of license? Of course, like I said, that conversation is a little more common in primary care, but definitely seeing that a lot more in some of our core medical and surgical specialties, because that's from our perspective, the only way that health systems are going to succeed in keeping an appropriate provider supply is by being able to effectively plan for the recruitment of and be able to leverage at top of license advanced practice providers.
And I think too, Travis, is at least some of the more recent engagements we've partnered with health systems on. I think this is an aspect that has probably been a bit overlooked by a lot, especially as, the recruitment of new providers becoming more challenging, shift in workforce, things like that, beginning to be more aggressive about succession planning and starting to look out as, as burnout continues to be an issue, other things like that, being a bit more aggressive about planning around it. I think has been a lot higher radar for, a number of engagements we've partnered on, probably the last 18 to 24 months more specifically.
Yeah, absolutely. All right, so we talked about measuring our market through market share. We talked about looking at the provider supply and relative demand. So that tells us where there may be specialty opportunities for the service lines we care to impact. So the next question we need to ask then is, well, what is our current state within those specialties? And the best way to look at that from our perspective is through provider capacity and access metrics. And for today's presentation, we're going to focus a lot on productivity, just as a proxy for access, recognizing that is an imperfect measure, but it is one that scales across all health systems and is appropriate for a national webinar. When we try to translate that into an individual client's environment, we see a wide variation in what each employed practice network or employed medical group is capturing and able to utilize to manage from an access metric perspective. And so there are a lot of things that we would recommend looking at that a lot of organizations either have some components of, have no components of, or in some cases have everything. But for today's purpose, this will do as a fine demonstration of the overall point, which is getting back around to that. We need to take our own practices into consideration when we're thinking about our growth opportunities, because I think in most cases, when we partner with a client to do this type of work, what we see is a lot of opportunity for internal growth that has a heck of a lot better ROI than recruiting incremental resources when we're still struggling to get some of our own resources as busy as we would like. So at a minimum, what works for every health system is looking at provider productivity. On the screen here is basically a sample network. I believe this is a large health systems orthopedic group where we can look at the distribution of providers, both physicians in blue and APPs in red, of their relative productivity against orthopedic benchmarks. In this case, when we look at this organization, we see relatively even distribution across each of the quartiles between 0, 25th to median, median above, and 75th and above. So this would suggest that within our network, two questions I might want to bounce against all my other metrics are: one, we have 6 physicians that are under the median in terms of productivity. How many work RVUs of orthopedics am I thinking that getting them up to the median provides for my network? And does that make, is that the equivalent of the 1 to 2 orthopedic providers that we might otherwise feel like we need to recruit? Can we get that same capacity by ramping up those 6? This network also suggests that, looking at our APPs, how are we utilizing them within the practices? Is there an opportunity to have some internal growth through better utilization of our own APPs, given that 4 of the 5 are below the median? And then contrasting that against, an extreme example that we've seen with a client, which this one's kind of fascinating. I'd call it maybe a CFO's dream for the current state, but maybe not one in which, I would feel comfortable thinking about the future state of competitiveness and access, especially around our access strategy within our market. So this particular group had hugely productive and market dominant group in this space, where you can see 36 of the overall 41 physicians were above the median, with the vast majority above the 75th percentile. And again, maybe another group where some of our incremental capacity and access comes through better utilization of our APPs, but also might portend that we really, should be focused on recruiting into this specialty, given that 24 75th percentile providers probably aren't providing a ton of incremental patient access. And so that's kind of the continuum on which we might want to think about practice capacity to help us think about our strategic recruitment decisions. Another way we might look at that is by regionalizing some of our productivity data. And the example we have on the screen here is in orthopedics, which again, for any of the specialties which do well with regionalization, orthopedics, cardiology, women's health, and especially primary care, regionalizing productivity data to maybe understand how we've made our investments and how well they're doing. So we're not looking at all of our orthopedics in one bucket, but kind of at the market level. This is an actual example from a client where, their Western market, so that cluster of zip codes they had built and defined as a sub-market, they had made an orthopedic investment in, but for the most part, had providers that are still ramping up quite a bit. So as they're looking at market share in their Western market and seeing that market share lag, what one of the, reflexes might be, if I'm only looking at that, well, we need to recruit and build orthopedics. When we layer in the demand and capacity, seeing that, we still have 3 providers at the 25th percentile or below, tells us we don't probably want to make those really expensive incremental orthopedic recruitments unless we feel like the existing providers are not going to ramp up and we need to talk about divestiture. Whereas compared to their South market, they still have providers ramping up, but they have a little more maturity in their South market. And if they're looking at a 3-year plan and kind of looking at the trends in productivity, maybe they expect that, over that 3-year period, they're going to have a lot of higher productivity providers, and that might, the South market, assuming it's something we want to invest in and market share data suggests we should, it might be an optimal place to think about adding a provider towards the end of a 3-year period. DJ, do you want to kind of take over and talk about geographic footprint considerations?
Yeah, absolutely. And one thing as I do that I might reiterate and continue to harp on is, so all those metrics just discussed, provider need, market share, productivity, access points, all those things. What we see most frequently is that, one, we need to understand those at the service line level to comprehensively evaluate what we think a strategy needs to be. I think just getting those data points together in one place is a common flaw and fault we see with a lot of health systems. However, the secondary point to that is then building an ability to continue to measure and track success is the secondary piece, especially for internal communication. How are we meeting the objectives we're setting? Being able to build some of those processes to continue to do that are aspects that I think need to continue to be focal points and kind of themes throughout the session here. So being able to kind of break that down into some specific components, the question we often get is, if we're starting to segment and break our market apart, how should we be thinking about that? And so there's a number of different ways that we recommend as we start to partner with health systems. Sometimes it's just common routes of travel. What does our historic market share look like? What are the demographics of the market? Are there some markets where we know there's significant growth happening now that we need to be aware of and be opportunistic about? Additionally, are there competitors that we know are building a new location or new side of service that we need to be either on the defense or be thinking about how do we optimize our ability to retain what we may be capturing from that market? So this example kind of on the left-hand side is just a sample of maybe some ways to think about that based on geography, common routes of travel, some of those other components, really trying to understand and break patients and populations into cohorts based on what we think is optimal for us as a health system to either attract more patients to our health system and or keep what we're currently capturing.
Yeah, and DJ, I would just add the inclusion of the Stark 3 market on this map is very intentional because we do still have a number of health systems, even very large health systems, who set their strategic market as their Stark market, which we think is probably a bit of a legacy from the early 2000s. And so just the broader point that every health system should have a broader view of their market as they're putting together strategic data and regionalizing that market so that we're thinking about the things listed on the slides.
Yeah, love it. Additionally, when we start to break down the specifics of geography and then the patient access piece, back to what Travis was discussing a minute ago around just pure productivity, we believe that patient access can be a number of additional things, specifically as we talk about geographic footprint around actual drive time and access to care being very critical. So the sample on the left is the greater Louisville market here, not too far behind me, maybe some, geographic locations, primary care locations throughout the market. If we're looking at something like primary care, we find if patients are more than 5 minutes away, regardless of kind of maybe you get into more rural markets, that number may shift. But for this sample, say they're 5 minutes away, that may mean there's easier access for those patients to get to a different primary care provider. So how do we need to think about strategically, geographically, where we're at today and where we need to go? And so being able to build some aspects around that proactively and understanding not just primary care, but specialty locations, the other ambulatory sites that are aspects like that, maybe incremental pieces we need to start to think about.
Yeah, and what we define as DJ kind of hit on, what your organization might define as accessible, is going to vary market to market, and it's going to vary just really health system to health system. But thinking about our array of not only primary care, but specialty access points, freestanding EDs, immediate care, urgent care, and then, depending on, if your market gets very, very, very urban, that can all look very different. But the broader point being that we need to understand what we're asking of our potential healthcare consumers in terms of accessibility for our services versus competition.
Yeah, and there's actually a question in the chat around if it's related to very urban markets, so walkable markets. So this sample on the screen is built at the zip code level. We recommend, depending on which market you're servicing and where your hospital location or facilities may be, getting down to census tract level information, and or maybe if you're a very rural market, getting more broad and starting to look at things maybe county basis and or CBSA level. So the general framework would be applicable based on the organization size and type, but understanding there's going to be very geography specific aspects. If you're in a walkable environment, getting down to census tract information that's going to be truly around how patients utilize services is going to be super important for your strategic growth. And then I didn't know this slide was going to bring up so many questions, but the other question around, travel time, we typically find based on location can be really whatever you want it to be. So the screen here is based on the actual location. So each of the red dots or red kind of little medical crosses are our sites of care. So we're trying to say our practices are at X location. How many patients are within a specific geography within that time frame, within a specific travel time from that specific site of care? We find that to probably be the best approach because it's based on where are we today and where do we think we need to go from a geography growth standpoint. So basing it off of our locations, we find to be kind of the best way to kind of start to handle that and approach it.
And I think, again, to Scott's question there, it's going to be a little market dependent on whether you're focused on where the employment relationship is, where if you're in a market that's heavily, younger families, where the school relationship is, or whether it's, an urban or suburban market where, patients are more likely to seek care near employment or at home. I think that gets a little market specific, but the broader point being understanding of the customers or the consumers we're trying to acquire, what we're asking of them, and what that looks like in terms of drive time.
So regardless of transitioning a little bit, regardless of which specialty or service line we may be looking to grow, our philosophy, at least at HSG, that we find to continue to be a major driver is primary care being the key to organizational success for ambulatory growth. That falls into a number of different buckets in our opinion. And so the first being, one, how are we performing in primary care specifically? So this is very data heavy slide, but kind of talking through some of the aspects is really wanting to understand of the patients that are receiving primary care services today, how many of those lives are we ourselves managing as a health system? And what percentage, I think it is often overlooked of just trying to understand comprehensively, if there's 100,000 people that are receiving primary care visits in our marketplace, what percentage of that volume is being provided within our practices and clinics? That's a component of starting there and understanding a baseline of what is our share of the marketplace from a primary care provider perspective is going to be critical to then building service line and growth objectives based on what some of that may be. Getting very specific, so within this slide, there's a couple things on the right-hand side. The top is truly going to be a way to start to think about what is the practice level capture of patients in our market area. So I pulled a sample for patients in Jefferson County, Kentucky, here in Louisville with me, and said, who are the actual organizations or practices that are servicing those patients from an office-based primary care perspective? So limiting data sets to only CPTs around 99201s through 215s. Let's limit to purely office-based visits provided by primary care providers. Who are the organizations that are in practices and where those patients are receiving that care? Then moving to the bottom half, getting into the specifics of then who are those physicians and or APPs that are impacting and servicing those patients? That can be very meaningful from understanding, are those providers employed by us? Are they a closely aligned independent group? Are they employed by competitors? Trying to truly start to understand the relationship of the individual providers with our health system can really enable us to build some service line growth strategies based on where we're starting from a primary care perspective. Anything to add to that, Travis?
No, I think it's just, as you said, the most critically important thing, and one that everyone who works with us, and DJ's heard this multiple times, I think it's the most important thing that we're able to measure under this, in this new kind of claims-based data world, is literally what percentage of the primary care market are we capturing as an organization? Because there are some markets where the statement is not true, but it's true for the vast majority. How we're doing in primary care really drives how we're doing as an organization. So I know like our South Florida folks may disagree strongly with me, where primary care is almost not a thing. But for the most part, being able to measure this metric and manage against it and strategically grow it is where we think most health systems have to be.
And so then starting to once again break that down by geography and or market areas. So not just saying, within maybe a number of the markets that we serve, getting into the same understanding of really what is our share of the primary care market currently. And then similar to some of the other metrics Travis has already, mentioned and alluded to, let's set a baseline, understand where we are today, and then be able to manage against it and build some targets based on what that is. And really with the goal of thinking about how do we grow our geographic footprint, as well as making sure we're utilizing our current capacity, in a very comprehensive way. So once we have that kind of baseline understanding of primary care providers in the marketplace, what our share of the market is, there's two main tactics that we think kind of start to trend from that if we're thinking about service line initiatives, especially related to primary care. And the first is going to be optimization of retention of patients within the system. So being able to, one, understand, we always recommend starting with those that we are a part of us. So the example given on the slide here, practices, primary care practices that are under our employ. Let's understand if a patient has an office-based visit with one of those practices, if they're then going to a specialist, say we're looking to grow orthopedics as the example, if we're looking to grow orthopedics, what percentage of the time are those patients going to one of our orthopods within a defined time interval? So being able to truly understand how patients are flowing through separate sites of care. For this example, if we maybe target the second column here on the left down orthopedics, what this data metric is going to help us start to understand is if a patient is seen within practice A, within that primary care practice, and then goes to an orthopod within a 3-month time frame, we find 3 months to be a good access metric for a lot of specialty care practices. There are some that take more time, like we've had some neurosurgery questions. It might take 4, 5, 6 months. So there is variation that exists, but we kind of find a good starting place for most specialties is about a 3-month time frame. So if those patients leave practice A and are referred to or receive a subsequent service from a orthopod, then 90+% of the time, or 88 and 91%, they're going to an orthopod that is affiliated with our health system, that kind of greenish middle green color. If you look at practice B in the Q2 22 timeframe, it's about a 50-50 split. So 1 out of 2 patients are actually going outside of the system for their orthopedic care. Is that something that we can incrementally bring into our health system? And is there opportunity to capture more patients from our initial core starting base of primary care? You can see this system did have some success doing that from their practice B, where they had a jump of up to about 78% in just a 1-quarter time frame based on what we see. Very tactile things, very operational things is what often enables us to really make it easier for patients to get from one side of care to another within our system. We always recommend starting to break that down and take it more granular to individual provider levels. So if there's providers within each of our individual primary care practices, behaviors are going to change and be different based on each of those individual providers. That Dr. DJ is not going to treat my patients the exact same way Dr. Travis is, and how we're actually going to get those patients to an orthopod or a general surgeon is going to vary. And so being able to understand the variance between us, and if it's something we can measure and manage to, is going to be the key there, because I guarantee you there are some things I'm probably going to do just because I like this orthopod that's not affiliated with the health system because I went to school with him, went to college with him 20 years ago. Maybe that's not something we can overcome, but starting to think through some of those opportunities that may exist for incremental patient capture within the system. Then the last piece specific to patient retention is really understanding if patients are going outside the system, who are they going to and why? So being able, like this example would be a listing of who are the actual orthopods and or their APPs that those patients are going to within that 3-month time frame. So we'd be able to see what's the relative volume and number of patients, as well as then what is the actual provider alignment with us. So being able to look at this competitor orthopedist A, I actually know from this example that that is a hand surgeon based on this client sample, that this specific organization, they did not have a employed hand surgeon. So a lot of that volume within their orthopedic service line is being driven outside the system or going to a competitor. That's actually led to them working on recruitment of an incremental hand specialist to their organization, because they've identified, one, patients are leaving, two, there's enough of a market opportunity that exists that we think if we were to bring that in-house, there's the ability to kind of draw more patient volume into our system. Then the last few things around, once we kind of have optimized our ability to retain patients, that we think has to be the focal point to start. Transitioning though, we also want to then think about how do we identify new access points for growth. So if we're building new practices, if we're looking and doing liaison efforts and trying to do business development outreach, after we've kind of made sure what we already own is well managed, secondarily starting to think about other opportunities for incremental capacity and growth from a service line perspective, that there's some ways that we identify and think that is the best way to start to measure that. So one is identifying who are those top specialists that are feeding our specialists now, or who are the top organizations or other entities. So for this example, we have looking at patients that are going to a primary care, to an orthopedic specialist. You can see that 25% of the time, that volume is coming from a family medicine physician. So that would be kind of under that measurement we were already looking at. But there's also 20% of patients are coming from the ED. There's another 12% that are coming from general surgeons in our market. You know, there's 7% that are coming from CV docs. So there are lots of different places that patients are coming from to get to our orthopedic specialists. So how do we start to identify who those other providers are and those other access and kind of incremental access points, so that we can start to do some targeted efforts around, you know, who we want to reach out to and what we want that to look like. We find this to be one of the best ways to really optimize the ROI on our liaison and development efforts, because we can get very specific in understanding these are the types of specialists we want to reach out to. These are the practices in which they are right now. And we can continue to measure our success in actually reaching out and, you know, engaging with those incremental providers. And then the last piece around here is when we start to look at some of those incremental access points, we find that starting with the ED and or urgent care locations are some of the lowest hanging fruit and opportunity, because one, ED patients are typically either patients with emergent needs and or patients that are just not 100% sure on what their appropriate side of care is. So being able to get very specific and partner with the ED to say, you know, are there ways to steer those patients to practice X versus practice Y for their specialty care needs, and, you know, breaking down some silos are some low-hanging opportunities that we see. And then the urgent care piece gets to, as we continue to look at data elements, we find them to be the least loyal patient population. So they're going to be the ones that are willing to shop around the most and are the most educated on how they actually utilize their healthcare services. So being able to integrate some of those pieces and look more broadly at, you know, how are those patients utilizing care now? How do we do some basic education, pricing transparency, education on our provider capabilities? Some of those elements seem to be very beneficial within the urgent care location specifically. And I saw a question pop up, Travis.
Yes, we had a question. What is your opinion on integrating quality outcome data within this model, possibly connecting growth to payer arrangements based on higher quality outcomes? Yeah, absolutely. So as you might imagine, again, when trying to create content that's national, quality is something I guess from our perspective as we work around the country, integration of quality and payer strategy by market is one of the things that I think we find we struggle the most with in terms of creating a cohesive and consistent message, because it truly is so different market to market. For organizations that are able to generate meaningful quality outcome data, which is not every organization, and truly have the awareness of what their payer arrangements are, especially on the outpatient and ambulatory side, which seems like maybe a silly statement, but I can cite several references of very large health systems whose employed network leadership have no idea what contracting has committed them to from a payer negotiation standpoint on the outpatient side. The more that we can do that, absolutely, and it really needs to be a part of this if there is the revenue opportunity that helps us, that makes us want to make that part of our strategy as an organization.
And so just a few wrap up things before we, I guess, transition to a more formal Q&A if there's incremental questions. We find that from a service line growth perspective, we think it really needs to be kind of three-pronged. So one, we need to comprehensively understand current state. Let's utilize all those separate metrics that we've kind of walked through. We've prioritized, 7 or 8 that we see very regularly. Well, as was just asked, adding in some quality indicators, payer indicators, probably also potentially more market specific, but other elements that, can be added into that. Let's look at those holistically and start to break them down by markets to understand what opportunities appear to be most relevant for us and the lowest hanging fruit for us. And once we've kind of started to identify our internal opportunities for growth, whether it be, just pure access capacity, keeping patients within the system, then let's start to look more externally for growth, because we find there's a lot of organizations where there's some internal things of growth opportunities that exist when we're always looking external. Maybe let's start to look internal, maybe as a starting place. Then the last two pieces here, so around making sure that our service line growth is data driven. We continue to hear a lot of organizations not making data driven decisions. We are continuing to harp that as we partner with health systems that's starting with data and then building measurable and repeatable systems to really be able to track the success. We see, a lot of variance by organization type, where some organizations use data, some don't use it at all. And I would say even less have repeatable systems for continued measurement. So being able to make sure that we've kind of built some of those capabilities so that we can continually keep a pulse on where were we historically, what are our objectives, and then measure our success over time, being, real critical components for where we want to go. So with that, I know there's only a few minutes left, but maybe transition to pure Q&A, Travis.
Yeah, absolutely. And I guess with that, maybe we'll give people a chance to populate the chat field and just quickly say thank you for the time. We appreciate the questions as we've gone through this. Let's see here. So of the questions we haven't had a chance to answer. So we had a question. Do you typically assess financial impact of which metrics to focus on? Also, do you have suggestions on setting targets for service line growth? So taking the last part of that first. So as we said, gosh, what feels like an hour ago, it was probably 40 minutes ago. I think utilizing a comprehensive metric of inpatient and outpatient ambulatory and physician office data, along with the patient flow dynamics that DJ was talking through in terms of retention, are probably the benchmarks that we see being the most relevant for once we start measuring those things all together. Let's get our teams engaged on managing against each of those things as a benchmark, and with our goal being continually improved performance. And I say that because every market is different, and every organization is different. And so our only measurement, our only goal really should be improvement. And I know, qualitatively, we could probably say, well, some service lines may be better set up to grow than others. And that is true. And I think that gets to the other part of your question, which is, how do you assess financial impact to help you prioritize some of these things? That again is a question that varies massively from health system to health system. Some organizations we work with have the data to create very strong, profitability judgments of profitability or contribution margin by service line or by specialty. Some organizations do not. I think we all focus on the same core specialties for a reason, and in which they are generally the most profitable. And I'll say, that's in some cases women's health, but in most cases it's heart, cancer, orthopedics, neurosciences, and then maybe the fifth one often varies between health systems. But at least for our core services in which we know we want to invest in, measuring the market share piece would be the most critical. And then DJ, we had another question. Do you have any specific guidance on how to design marketing plans to influence service line growth? For example, when the goal is incremental growth, what type of volume increase is even reasonable to achieve with a campaign?
So yeah, that's a great question, and one that I think we get probably more frequently than not is one, what type of target is realistic for us as an organization? And so I honestly probably don't have too much specific guidance on designing of the marketing plan, but being able to, on the goal target aspect, there's a lot of components where being able to get granular at the individual service line level. So if we're looking at orthopedics, let's look at the subcomponents within orthopedics and understand maybe orthopedic X-ray is an area where we're only capturing 40%, but our orthopedic MRI capture is around 60%. Is there an immediate opportunity to get our orthopedic X-ray capture in line with our MRI, and that being potentially a 20% jump in that market share objective? So we often start to set internal targets as an initial starting place of being able to understand the capabilities we have currently, and let's look at sub aspects within that to build realistic targets and understand the competitive dynamics of those. So there might be, if you're looking at orthopedics and looking to grow outpatient joints, but you have a tertiary competitor that is capturing 80% of the market already, that might not be the area you want to focus. You might want to focus more on the ancillary services. Let's let the joints go away. Let's focus on the aspect of keeping the imaging and other services in-house the best we can. So being able to get as granular as possible and understanding the dynamics within a specific service line is where we think building reasonable objectives and targets, it gets down to that component.
Great. And then DJ, we had one final question. In the primary care productivity section, you were using work RVUs as a measure of productivity. Thoughts on using other measures like slots available versus slot utilization or minutes occupied on their schedule? So that's a great question. So typically when we engage, we typically focus on 3 or 4 things. So RVUs generally just as the measure that 80%, if not more, of health systems utilize to measure productivity, as something that we know is easily capturable. And as we advise people, can say this exists in your system, make sure you're utilizing it. Other data that we would tend to collect. So yes, absolutely love slots, in terms of schedule. One, we love to look across, if we're using primary care as an example, look across all of our primary care providers at what slots are even expected. So before we can get to how many are available, what's expected. So there's a lot of organizations where 36 clinical contact patient hours means 36. There's some where that actually means 28 because it's not enforced. So what are our actual expectations of productivity from a scheduling type of perspective? What's available, then what's utilized? We love to look at third next available new patient appointment, and third people sometimes ask why third. It's because that tends to eliminate special cause variation of a patient canceling or something else that might create an artificially soon access spot. But realistically, across our providers, when is that third next patient able to get in? And then it might vary otherwise. Looking at the number of, it kind of goes back to scheduling templates, but looking at rates of no-shows when we're considering how many slots get utilized, or what are we doing to kind of mitigate the expected utilization rate of our schedules is another one. But productivity provides just across all organizations a pretty reasonable proxy, because once you're above the 75th percentile, I mean, I've spent my career basically advising health systems to get their providers to the 75th percentile. But the further we move along in healthcare, the more we think about how unsustainable that workload becomes over a long period of time, in terms of physician burnout, in terms of staff burnout, in terms of just the logistics of working here in 2023 with the space and the staff we have available and trying to run a practice at that level. It's just a challenge. I'll just leave it at that, given we're at time. So with that, with questions being done, Tom, anything to wrap up?
Yeah, DJ and Travis, thank you both so much for being with us today and sharing your expertise. And also another thank you to HSG for sponsoring today's program. Please complete the short survey that will launch on your browser once this webinar closes. You can also use that survey to request a copy of today's slides. I will follow up this afternoon with a recording of today's webinar, as well as that link again to the evaluation. But that concludes today's presentation. Thank you, and wishing you all a great afternoon ahead.
Thank you.
Thank you.